Hello everyone. Now today we'll be discussing about the nephron physiology. Normally we know that nephron are the structural and functional unit of the kidney. They are the basic unit of the kidney. So they are both structural as well as functional unit of kidney. They are around 1.3 million nephron in each kidney. Okay, so to understand the nephron physiology, we have already discussed about the parts of the nephron, that it is divided in two parts, that is renal corpuscle and renal tubules. In renal corpuscle it comes the glomerulus and Bowman capsule, whereas in case of the tubule it comes the proximal convoluted tubule, then descending limb of loop of Henle, ascending loop, thick ascending loop of Henle, distal convoluted tubule, collecting ducts and collecting tubules. These are the part of nephrons. So to understand, we have already discussed also in the previous lecture that there is for urine formation there are the three steps. One is the glomerular filtration, that is GFR occur, then there is tubular reabsorption and tubular secretion. We have discussed about the glomerular filtration and glomerular filtration rate, that what is the net force, how the blood which come into the capillaries goes into the Bowman's capsule due to passes through this filtration barrier of capillary endothelium, basement membrane and podocyte, and then it goes into the Bowman capsule and into the proximal tubule. When discussing about the function of the kidney, I have told you the main function of our kidney is to reabsorb the all useful substances that is required for our body. That is the main function. Then there are a lot of functions also, like excretion of the harmful substances, formation of urine, then acid base balance, water balance. We have discussed about few things in previous lecture. If you are not seen the previous lecture, go to my playlist. In the USMLE section you will find the part 1 of renal system revision, then part 2. This will be a part 3. But before part 3 there is another video of counter current mechanism, and it is a very important concept to understand all this basic renal physiology. That is very important, how the urine get concentrated, how urine when it is dilated, what is counter current mechanism, what are the counter current exchanger, counter current multiplier. That concept is necessary to understand this renal physiology. Okay, now moving towards the nephron physiology, since we have discussed about other glomerulus and Bowman's capsule and glomerular filtration rate, now this glomerular filtration, which is GFR, which is 125 ml per minute. I have told you previously also, but our urine formation is only 1 ml per minute. So 124 ml of water component get reabsorbed. Now this 125 ml has passed the Bowman's capsule and reached into the proximal convoluted tubule. Now we will discuss in detail what are the steps, what are the things going there that will leads to the reabsorption in detail. Okay, so this is the picture of your proximal convoluted tubule. This is the lumen of your lumen. This is the lumen through which the urine is passing, or the GFR is passing. Now when it passes through it, there is surrounded by three sides surrounded by the tube, renal tubules. Then renal tubules, this is the proximal convoluted tubule principal cell. Okay, this is the luminal membrane, this is the basolateral membrane. In the basolateral membrane, there is sodium potassium pump. This is ATP dependent. So for this, ATP is required, ATP is used, and the sodium is pushed into the interstitial blood, interstitial fluid, and potassium is pushed into the cell. That is the main function of this sodium potassium pump. So now sodium is out from this cell. Since sodium is out from this cell, now there will be lack of sodium in this proximal convoluted principal cell, in this cell. Okay, since when there is less sodium, now the sodium will be get absorbed from the lumen, your GFR, your what you call, which is going to be urine. So from lumen the fluid is passing, from there now sodium will be absorbed. Sodium will absorb by, there are a lot of mechanisms. Among them one is sodium glucose co-transport. Means that in proximal convoluted tubule you have to understand that there are absorption of lot of substances. Maximum your useful substances will get absorbed in this proximal convoluted tubule. Okay, So now sodium glucose co-transport will, the sodium will come, then glucose will come, and this will again, they both will be co-transported. When both will combine with that receptor, then only this will move inside and both will be transported into the cell. Okay. There is another form which is known as the sodium hydrogen exchanger. This was co-transport, and it will only work when there is a glucose, and glucose with sodium, this will co-transport inside the cell. Then they usually get distorted, and the glucose gets separated and it goes out into the interstitial and into the blood by ultrafiltration. Okay, first by the facilitated diffusion, then ultrafiltration this will go. Okay, now there is another pump which is known as the sodium hydrogen exchanger. What it will do, since there is low sodium due to this pump inside the cell, sodium will come, and in place of sodium, this hydrogen will go out into the lumen. So this is going on. Again, I am focusing on this pump, that you have known that how absorption we are talking in the luminal surface, sodium and glucose has been absorbed, there is no problem. There is another pump called sodium and hydrogen exchanger. Sodium will get absorbed in exchange of hydrogen. Now you have to remember one more thing, that in proximal convoluted tubule or any part of our renal tubule, there is no provision of absorption of bicarbonate ion on its own. There is no any system, there is no any pump, there is no any transport system that has been made in our kidney that will directly absorb this bicarbonate. So in the form of bicarbonate, it is not get absorbed. That you have to understand. Since bicarbonate is not going to be absorbed, now what we will do? The condition is that we have to convert in such a way that it should be get absorbed. Okay, so what we will do for that? With this hydrogen ion that has been secreted will combine into this bicarbonate ion and form the carbonic acid. Okay, this carbonic acid then in the presence of carbonic anhydrase, that is present inside the cell as well as in the luminal surface brush border, that will convert this H2CO3 into CO2 plus water, then carbon dioxide and water. So what has been done? Bicarbonate ion was coming. Okay, the hydrogen ion that has been secreted out will combine with this bicarbonate, form the carbonic acid, and this carbonic acid will be then dissociated into the carbon dioxide plus water. Now carbon dioxide will be easily, it is a gas form and it is lipid, so it will be easily diffused through the membrane and goes into the cell. So important thing is that bicarbonate we cannot absorb, but carbon dioxide can be easily diffused through the membrane and enter into the cell. As soon as carbon dioxide enters into the cell, it combines with the water and form the carbonic acid in the presence of carbonic anhydrase. So this carbonic anhydrase playing a major role in the absorption of your bicarbonate. In this whole ion you cannot absorb as a sole. You combine with the hydrogen, form carbonic acid. In the presence of the carbonic anhydrase, it is broken down into the carbon dioxide and water. This carbon dioxide, when diffused through the cell membrane, when entered into the cell, it combined with water. In the presence of carbonic anhydrase, it again forms the carbonic acid, and this again dissociated in the previous stage of hydrogen and bicarbonate. Now your bicarbonate ion will be again diffused into the interstitium and finally into the blood. So in this way, your bicarbonate is get absorbed. Okay, and this hydrogen ion that has been dissociated will again exchange with the sodium. So I hope you have get clear idea about this principle proximal convoluted tubule cell. Here two things is important. One, glucose is get absorbed, amino acid get absorbed, sodium is getting absorbed. Around 60 to 80% of sodium, there is sodium glucose transport, sodium exchanger, these are getting absorbed in the proximal convoluted tubule. Okay, and the important two thing is about this sodium hydrogen exchanger, which help us to absorb your bicarbonate ion as well. Okay, when we have understood this scenario, so what is the net result? Net result is sodium getting pumped out, so sodium is getting absorbed into your blood. Okay, bicarbonate is getting into your blood, and other glucose, amino acid, glucose is getting into your blood. This will come into cell after filtration, amino acid getting absorbed into your blood. So these are the fate of your proximal convoluted tubule function by help of the different pump or exchanger present in the epithelial surface and basolateral surface. Okay, now since you have understood the absorption of the ions and glucose, vitamins, amino acid. Now there is another thing, two major things that you have to understand. One is about angiotensin 2. You know that angiotensin 2 is released only in the, previously I have discussed in previous lecture that when there is low fluid, when there is low sodium chloride content reached to the macula densa, then there is a chemoreceptor at macula densa which sense it and activate the J cell to release renin. When there is low BP in the afferent arteriole, then that will be baroreceptor is present there, low BP, that will sense it, stimulate the juxtaglimeter cell and release the renin. We'll discuss in next subsequent lecture about renin, angiotensin and aldosterone mechanism in detail. Okay. So what happened from here? Renin is released. Renin convert angiotensin to angiotensin 1, which is finally converted into the angiotensin 2, and this angiotensin is formed due to hypovolemic state, due to less fluid inside the body. That you have to understand. Since it has been produced, now what we will do? This will activate this sodium hydrogen exchanger. So in case of this condition, sodium and hydrogen exchanger will be activated. Why it has been activated? Because sodium will be more absorbed. Sodium will be absorbed. Then there will along with that water is also get absorbed, and water is absorbed in the isotonic condition over here. So now sodium and water content will be increased in the blood volume. That goes to the cell interstitial fluid and the blood volume. So your BP will try to maintain. Body is trying to maintain the BP. Okay. So angiotensin 2 is more sodium, the activation of this form. Now on the collateral side, what is going on is this sodium is getting absorbed. In place of that, what is coming out? Hydrogen. Now hydrogen, more hydrogen. Usual rate is going on. What is inside the body? There is a usual basal rate that should be go on. But this, due to this, there is more activity of this form. So more sodium going in, more hydrogen coming in, out. Since more hydrogen is coming out, it is combining with the bicarbonate, forming the carbonic acid, again into dissociated into the carbon dioxide and water, which is again get absorbed, again it form the carbonic acid, which is again dissociated. The whole process is, this process is also getting increased, exaggerated. Because of this bicarbonate absorption has been increased than the normal due to the presence of this angiotensin 2. That you have to understand very well. So this your angiotensin 2 has activated this, and this also activated your this procedure, and bicarbonate has been absorbed more. Because of this, although body has able to maintain its BP by the help of angiotensin 2, on the contrary side, it also causes increased absorption of the bicarbonate, which leads to the alkalosis. So angiotensin 2 with activation of angiotensin stimulate the sodium hydrogen exchange form, promote bicarbonate absorption, leads to the alkalosis, that is contraction alkalosis. Because although it is trying to maintain your BP, increase the blood volume, but your blood volume is less. Despite of the less blood volume, there is alkalosis. This is called the contraction alkalosis. Okay. Now there is another point you have to understand about the hormones. Since I am talking, this is parathormone hormone. Okay. So parathormone hormone has function is in the intestine. It helps the vitamin D to absorb the calcium and phosphorus. So from intestine, calcium and phosphorus is absorbed. It comes into blood. Through blood, it comes to the kidney. When it comes into the kidney, this parathormone inhibits the sodium phosphate co-transport. There are a lot of co-transport here over here. There will be the amino acid. There is with the phosphate as well. Since this co-transport is inhibited by this phosphate, then what we will do? This phosphate will not be absorbed. Co-transport means both, like sodium glucose co-transport. Both get attached over this transporter, then get attached. It will goes into inside the cell. This is the function of co-transport. Counter transport is one is getting inside, another is getting out. But co-transport is both get attached to that form or that carrier, and both is getting absorbed into the cell. Since this is a co-transport, so PTLs inhibit both sodium and phosphate absorption. Since sodium is absorbed by other mechanism, this is not going to be much affected, but phosphorus is not being reabsorbed. It is absorbed through the intestine, So your calcium and phosphorus both has been absorbed and come into the blood. But when it goes to the renal tubule, kidney, from kidney it is what is doing? It is excreting the phosphorus. The function of bile hormone is absorption of calcium and phosphorus from the intestine. But when it goes to the kidney, it reabsorb the calcium, helps in reabsorb the calcium, but excretion of the phosphate. So main function is increase your calcium level, but reduce the calcium level in blood of your phosphate, because it is the blood product that has been filtrated. Now phosphorus is getting out. That is the function of your parathermal hormone. Okay. So you have understood about the proximal. This all thing is going on in the proximal convoluted tubule. So we are discussing it. Okay. Now there is another two things you have to understood about is drug. What are the diuretics? Diuretics are that increase your urination. Okay. So this in proximal convoluted tubule, when you talk about anything, when I talk about the nephron physiology, then let me discuss little about the pharmacology as well. Okay. What is happening? We are discussing the physiology of the proximal convoluted tubule, then we will discuss descending loop of Henle, ascending loop of Henle, distal convoluted tubule, collecting ducts and collecting tubule. According to the physiology, we will also discuss side by side about the pharmacology, that we knowing this physiology, what can be done for the management of the patient in certain clinical situation scenario. Okay. Suppose we are giving mannitol. These are the diuretics that act in the proximal convoluted tubule. So I am talking about only this at present. We will discuss separately about the pharmacology as well. So mannitol will come here in the lumen. It is an osmotic particle. It will absorb. It will hold the water that is present into the lumen. And since mannitol is not getting absorbed in any part of your tubule, now it is going to excrete into the urine. It is going to excrete into the urine, but with holding the water, because mannitol itself is osmotic particle. So mannitol with water, they are going to be held together and getting excreted to your kidney. What is the use of this mannitol? This mannitol will use to decrease the intracranial pressure and intraocular pressure. These two is the place where mannitol is used, and it is acting in the proximal convoluted tubule. That you have to understand. Okay. So main function. This is the diuretics that will act in the proximal convoluted tubule. It is very important, and it will help in decreasing the intracranial pressure and intraocular pressure. That you have to understand. Okay. Now come to the second point is acetazolamide. This acetazolamide. This acetazolamide is what? This is a drug. It is a diuretic. It acts in the proximal convoluted tubule, and where it acts in this carbonic anhydrase, Ca, carbonic anhydrase. This carbonic anhydrase is inhibited by this acetazolamide drug. So what is doing? It is inhibiting your bicarbonate absorption syndrome, basic ion absorption syndrome. Since it is inhibiting it, what will do? This bicarbonate combined with hydrogen to form bicarbonic acid. This carbonic acid will dissociate to form carbon dioxide water. If it is not getting dissociated, it remains only in the carbonic acid, then it is not going to absorb. If it is not going to absorb, it will combine with the sodium and form sodium bicarbonate. Okay, and then it will get excreted. So there will be a diuresis of sodium bicarbonate. Okay, now what are the implications of it? One implication will be, in case of, since bicarbonate ion is getting out from your body, we can use in glaucoma. Since bicarbonate ion is going out from your body, you can use in alkalosis. Since if your body has alkalosis and if you give this, then bicarbonate ion is excreted. Although kidney will try to compensate to excrete the bicarbonate ion, but when you add this will again more excrete the bicarbonate ion from body. So where you can use in glaucoma, metabolic alkalosis. Then there will be altitude sickness. When you go to the high altitude, you will respire more. When you will respire more, there will development then carbon dioxide will be in search of oxygen, then carbon dioxide will be washed out more. Since carbon dioxide is going out, there will development of respiratory alkalosis. Now your whole body's pH system has alkalosis. It will again try to excrete out the alkaline ion from your body, maintain your pH. So in altitude sickness, patient going to the climbing or a normal individual who is going to climbing, this acetylcholamide will help a lot to maintain the pH of the body. Okay, so there are other conditions as well where we can use, but I have discussed the major one. There is cerebellar pseudotuber cerebrally. Okay, so there are the other conditions which we will discuss in detail when we discuss about the pharmacology. Okay, so you have understood. So since you can see how many uses, if you understand the physiology, then pharmacology is just to alter your physiology. The drugs what have been made is just, if you understand correctly the physiology, then that changing the physiology, restoring the physiology is function of all the drugs. Okay, so you have understand that also. Now there is, let's comes to the pathology. When you discuss about each part like PCT, if there is, we have discussed about physiology and pharmacology as well, then there will be disease pathology as well. The pathology will call as a Fanconi syndrome. What is Fanconi syndrome? It is the reabsorptive problem. Since there are a lot of reabsorption going on PCT, but if the reabsorption will be not occur, then that situation is called Fanconi syndrome. There will be no reabsorption of glucose, no absorption of amino acid, no reabsorption of bicarbonate, no reabsorption of phosphate, no reabsorption of sodium. So there will be reabsorptive problem. Due to that, all the substance will be washed out through the kidney. It will be go out in your urine, and since there is a reabsorptive problem, there will be also development of the proximal tubule acidosis. Okay, so you will say what are the causes of this development of such condition, that this is a very useful thing for our body for a reabsorption of all the useful substances, major part going into the proximal convoluted tubule. So we have to know the causes. The causes are normally hereditary causes, includes Wilson's disease, glycogen storage disease, cystinosis. Okay, then other condition are like ischemia, then maybe lead poisoning, other nephrotoxic drug like say you can ifosfamide, cisplatin. Then even if you are going to manage your HIV patient, then you have to understand about the renal function, because tenofovir, which is an NRTI, nucleoside reverse transcase inhibitor, and it is a major component of your HIV medicine, that is tenofovir. So you have to understand that when you are going to use tenofovir as well, because patient may develop Fanconi syndrome. Although we have alternative tenofovir, efenamide, TAF is there. Okay, and another condition. So we have a lot of, I have told about ifosfamide, cisplatin, tenofovir, and another is expired tetracycline. That is also important. Okay, so expired tetracycline, ifosfamide, cisplatin, and tenofovir. TDF. These are the drugs that is responsible for your Fanconi syndrome. Other are lead poisoning, ischemia, okay, then hereditary disease like Wilson's disease, glycogen storage disease, cystinosis, trypanosomia, there is another term also. Okay, so you have to understand that as well. Okay, that is tyrosinemia, that is tyrosinemia. Okay, so in tyrosinemia also there will be Fanconi syndrome, multiple myeloma. These are the conditions where there will be such Fanconi syndrome, and you have to also identify this condition as well. Okay, and there might be a question related to this in your USMLE section. Okay, so let's end it over here, and we'll further discuss about the other part as well. We can actually discuss a little about this thick limb of loop of Henle, that is thick descending limb of Henle. The important point is that this section doesn't have permeable to the sodium. There is absorption of water only, and the water absorption diffusion occurs due to the medullary concentration. And for understanding this, you have to see the countercurrent mechanism lecture, where you will understand that how medullary hypertonicity, medullary hyperosmolarity will leads to the water absorption in the descending lemma group of alveoli. Okay.